Joining us. My name is Christina Dean, and I am the opioid coordinator for Munson Healthcare, and I work with the Michigan Opioid Partnership. And today we're going to be talking about the nursing role in treating opioid use disorder. So we would appreciate if you can keep your microphones muted when we are presenting. If you have any questions or comments, you can raise your hand or put it in the chat and we will try to address it as it pops up. Next week, the Community Foundation will send out a follow-up email, including the slides and recording instructions for claiming your continuing education and any resources shared in the chat. Nurses will be awarded 1.5 contact hours for continuing education. There will be a evaluation to complete to claim that. And there is right here a address if you have questions regarding the education. So as I said just a second ago, my name is Christina Dean. I work in Northern Michigan in Traverse City for Munson Healthcare as our opioid initiative coordinator. So I guess I describe my role as a bridge from the hospital to the community for resources, building our efforts into treating substance use disorder. Dr. Radmacher is also going to be presenting, and we have nothing to disclose. This is our agenda. Learning objectives. We really do want to improve the understanding regarding addiction and treatment options. And I'm going to start with my personal connection to this work. On the left, the picture is my brother Nick, who sadly died at 17 years old related to a methadone overdose. That methadone was prescribed to his 16-year-old girlfriend at the time. And the photo on the right is my biological dad, Tim, who struggled for addiction most of his life and died of an OxyContin overdose at 51. Unfortunately, my experience is like many people's, where there's not another opportunity for them to get help and recover. And I say this and I share this because there are options that are available, but there's a lot of gaps and barriers to receiving the treatment for addiction. I hope today that with Dr. Radmacher, we can help improve the understanding, the resources available, and gain some more champions to change how we care for this patient population. This screen is part of the NORC of Chicago, the University of Chicago. It's a map of Michigan. They provide actually the whole United States with this National Opioid Misuse Community Assessment Tool. And it is an interactive data visualization of the national county level drug overdose mortality rate. The tool provides overdose mortality rates for counties in each of the 50 states with social determinants of health, such as unemployment rate, poverty rates, disability status, and users can compare your county or state to any other county or state and where we stand in the nation's rating. The current graphic is only county level for Michigan, and it shows data from 2016 to 2020 without any of the socioeconomic factors applied. We do have some pretty high counties in some areas that we're working towards changing. This map is from a study. It's a little bit older of a study. It's from 2019, but part of the study was to identify the options for care and access to behavioral health and substance use disorder treatment in Michigan. The data shows only that about 20% of people receive treatment, which leaves more than 500,000 people untreated for substance use disorder. And as you can see, there are pretty sizable area where there's very limited options or no options. So with from 2019 to now, we have dedicated efforts to improving the treatment, and it's likely got more coverage areas than what this map shows, but I haven't found an updated map to provide the data to support that. So with that previous statement and the limited options leads us into why in the emergency department are we initiating this treatment. The emergency department initiation for treatment for opioid use disorder is unique, but it also provides the opportunity to intervene and help patients that may never have sought out medical care until they're in their crisis mode or after an overdose, going through withdrawal, or have an infection related to it. It might be the only place available for them to get that basic care and introduction into what options might help them. So that is, I guess, the main reasons why we are launching this in emergency departments. And the basics of opioid use disorder, I'm going to hand this over to Dr. Rademacher.
All right. Thank you all for coming. I'm so excited to be able to do this presentation with Christina today. I'm Nick Rademacher. I'm an emergency physician in Grand Rapids in Trinity. And I am the lead clinician for the Michigan Opioid Partnership. And so over the past 3 years, together with the Michigan Opioid Partnership and certainly with MHA's assistance, we've been able to initiate and help hospitals initiate medication for opioid use disorder treatment in the emergency department in what is it now, between 70 and 90 emergency departments in the state. I think currently we have around 45 that we're doing this year. And so, we've been passionate about this project, and we really think that emergency departments are the place, or at least one place, where treatment for opioid use disorder can start. Certainly other areas, other parts of the healthcare system and even legal system can pitch in, but I really do think this is a contribution to the overall health of our communities that we can make. And as you can see, I think we've all heard, the number of overdose deaths based on opioid exposure has really just skyrocketed in the past 10 to 15 years. I think this historically started where the number of opioid prescriptions increased, and then it kind of, it really just kind of hummed along in the early 2000s. And then there was a bit of a backlash where we were finding that patients were developing opioid use disorder. Certainly these substances were more addictive and more disruptive to their lives than we initially let on. And so prescriptions started to fall, and because opioid use disorder is a chronic condition, it's not that if you stop prescribing an opioid to someone that they're just going to stop using opioids. They will find alternative sources. And so this is where you have the explosion of synthetic opioids in around 2013, 2014. You can see the graph really starts to take off. Number of deaths start to rise. And this is where we are right now. Is you can see there was a bit of a plateau. We were making some progress in the late 2010s. You can see this plateau starting in 2017, 2018, 2019, and then the pandemic hits, and we just have another leg to this graph, and we're still continuing to trend upwards. And so this is just another illustration of why it's so important that we continue with this work and try to get people on medications for the opioid use disorder, because we know that it's the safest thing to do. I think we've all seen this. People with opioid use disorder have a 20-fold higher mortality rate. And these aren't people in their 70s, 80s, and 90s like we'd see for those with COVID-19. These are young people, right? 20s, 30s, and 40s. They have an additional 40 or 50 years of life to live. And they don't make it because of overdoses, infectious disease, endocarditis, increased risk of trauma, increased risk of depression and suicide. And so multiple studies, 3 that I'm aware of, 1 in Canada, 1 in the US, and 1 in Australia, have showed repeatedly that for those coming to emergency departments after an overdose, have a 1-year mortality rate of between 5 and 10%. It's not quite as high as someone with acute chest pain, but it's close. And again, remember, these are very young people in the prime of their life. And so I think we all pay attention to this. So what exactly is an opioid use disorder? In the DSM-4, so DSM is the Diagnostic and Statistical Manual for the psychiatry diagnoses. And a couple of years ago, the 5th edition came out. In the 4th edition, you would have things like opioid abuse, opioid dependency, opioid withdrawal, and they really consolidated all these substance issues into use disorders. And so I think this is better terminology, because we do, I think, need to see it as a medical condition. And terms like abuse, aren't all that helpful. And so there's really 3 categories, and you have, these cravings where you continue to use more than intended. You can't cut down. You start giving up activities to obtain substances. And then you have these physiological changes where you have tolerance and withdrawal. And then finally, you have consequences. And so for someone to have an opioid use disorder, you need to have at least two of these 10 items. And you have a severe opioid use disorder with greater than 6. And so, and it can't just be tolerance and withdrawal, because, for example, someone has pancreatic cancer and they're on OxyContin, they're going to develop tolerance and they will withdraw if they stop that medication, but they don't have an opioid use disorder. And so you have to have at least 2, but not just those 2. And so if you think about the patients we see, they almost always have a severe opioid use disorder in the emergency department. Right? The people we see are having cellulitis, abscesses, endocarditis, and overdose. They're using when dangerous, they've lost their jobs, they've lost relationships. And so it's very easy for them to get to 6 items in this scale. But opioid use disorder is the correct terminology, and these are the things that we're looking for when we're trying to make the diagnosis of this disorder. So I think some ask, like, why is this being medicalized? And the reason that these are real medical conditions is because there's real physiologic changes. And so people, mu receptors, the receptor that opioids work on within the body, are at multiple levels, right? They're in the skin, they're in the nerve roots, they're in the spinal cord, they're in the brain. And when you look at people with opioid use disorders, just structurally, their brains have changed, which is why this is such a chronic condition, is because once you have an opioid use disorder, just your brain does work differently. You have these cravings. You're often the first thing you do when something difficult comes up in life is you want to go back to what your brain is telling you to do, and that's continue to use an opioid. And they get high levels of rewards for doing this. And the sensation, the fear of stopping is high. And so you have, fear, and reward areas that are rearranged by opioid use disorder and alcohol use disorder, cocaine use disorder as well. But today we're going to talk about opioid use disorder. We mentioned how the DSM-5 had changed the way to describe people with problematic substance use. And I think what we're all trying to do is to humanize the disease, because 80,000 people per year are dying now from this. And when we're trying to get people to engage in care, to come to us for treatment, it's helpful, if we see them as people with these disorders that we can help. And so to describe someone as a person with a substance use disorder, I think is much more digestible than trying to get help to someone who you describe as an abuser or an addict, a junkie, for example. And so sometimes, patients will describe themselves in these ways, and then we just can rephrase it and say, oh, you said you're a junkie, but, then say you have a substance use disorder, or they say that they'll relapse or fall off the wagon and say, oh, you were in recovery and you returned to use, but we're going to try to get you back into care. And so just trying to use more humanizing language is really like half the battle, because I think the majority of the obstacles we see with the emergency departments we've worked with is that stigma is just the primary thing we have to overcome, both with patients and providers, in order to get through and try to increase the rate of treatment for our patients. And I think, as nurses, you spend a lot of time, you often get the first interaction, and that first interaction that they have with you is really going to make or break whether they stay to even talk to me. Because if they have a bad experience in triage, if they're called something derogatory and upfront, like, they're going to leave, they're not going to have patience for me, they're not going to want treatment, even if I come to them with options. And so I think, it's so important that we engage nursing and have you guys be the ones that you really, kind of pave the way to a smooth interaction with other providers a little bit later. We have a polling question for everyone. Yeah, I won't read it to you. You guys can read it. Okay. So I'm seeing my quiz results. I don't know if you're seeing yours, but the answer was B. It's 5 to 10%. Okay, I'm going to pass it over to Christina so she can talk about how to assess for opioid withdrawal in your patients.
I apologize. I am having major technical difficulties with my computer and it just totally restarted. So I'm on my phone now and I don't know if I can take control.
If you want, do you want me to scan?
Yeah, if you can go to the slides, that'd be great.
Okay.
I think I might have had an update that I didn't do. Okay, so probably most of us are familiar with assessing alcohol withdrawal, and there are recently we've implemented, and part of the best practice is opioid withdrawal assessment, which is COWS. So it's a clinical opioid withdrawal assessment. And there are a variety of symptoms that we have probably all seen caring for patients, but maybe have not recognized as such. The signs that we see objectively are tachycardia, diaphoresis, restlessness, agitation, vomiting, diarrhea. The subjective signs that people complain of are nausea, abdominal pain, body aches. That's probably the most common complaint I hear from patients who are going through opioid withdrawal, and also when it's not treated properly, what makes them leave. The restlessness, runny nose. So those are all symptoms. It depends on the withdrawal onset. It depends on what they use and when they've last used and how much they use. For short-acting opioids, it's typically around 12 hours, sometimes as early as 8 hours. Long-acting opioids has a more commonly onset of withdrawal symptoms at 24 hours. It could be 48 to 72 hours if they use methadone as their opioid of choice or drug of choice. There are often multiple physical, emotional, and mental exacerbations that go with withdrawal. They are in a terrible state. They feel terrible. They've often a lot of behavioral health issues are brought out with the withdrawal. If we can go to the next slide. So this is an example of the clinical opioid withdrawal scale. We've learned a lot in the years since the beginning to treat patients who are in withdrawal. Many of the practices are common in other areas, but now having a formal treatment option and assessment option has been helpful for guiding how we treat patients. So this is the most common symptoms that people experience with withdrawal, and it really mimics the CWA. So you can do your assessment and see where the patient's at. Some of them are questions that they have to reply to, but at the end it gives you a score, and that can guide the dosing for medication if that is the next line of treatment for the patient. So some of these stigmatizing practices are not only hospital, they could be ambulatory clinics, but there are many that are still commonly practiced according to patients who are seeking treatment. And I think this really goes back to the treating addiction as you would treat any other chronic disease. So discharge from a practice for a positive urine drug screen is unfortunately a pretty common practice in outpatient treatment. But what it really should be is if they're not showing up for appointments or whatever the standards are for any other person who's coming in for a chronic disease treatment, it shouldn't differ from that. Random urine drug screens, if you want to screen your patients, the recommended practice is to screen them every time. I mean, sometimes they are using other substances, but that's also a way to look into like, well, what's going on? Why isn't this treatment? Is this treatment not enough, or do we need to do something different? More of a guide for changing the course of treatment versus getting rid of the patient as a patient. Sometimes the course of treatment is time frame limited, which is odd to me because with like many other chronic diseases, we don't put a limit on treatment and there's no expectations on when the patient will be better. Addiction is also one of those diseases that also shouldn't have a time limit or a time frame on when they should be done with treatment. And then I think this has gotten better, at least from my experience, but some of the terminology using for patients who are coming in for treatment with related to substance use disorder is drug seeking in the hospital, in outpatient settings, wherever it might be. And the thing is that maybe those treatments aren't addressing what they need and it needs to be a different treatment. So rather than calling them drug seeking, maybe it just needs to be a reassessment to evaluate if this is the best treatment for them. Next slide, please. So the evidence of medication for opioid use disorder. And this is something that has reduced overdose death and complications. It's encouraged treatment and recovery and has also reduced the stigma of addiction. It really saves lives and promotes recovery from addiction. It does require quite a bit of community involvement along with screening and access. You can see from this map that we are probably, well, we are one of the higher states with increase to all drug overdoses from January 2023 compared to December 2022. Next slide, please. I think the biggest thing that we need to focus on is that addiction is a treatable chronic disease, and there are many people who recover from it as long as they have the options for treatment. So the goals for treatment, medication or not, mostly I speak to medication treatment because it is beneficial. It's kind of that bridge from to get them to the other side. I mean, we use medication in so many different areas of medicine that this really shouldn't be looked at as something different. But it does help the reduction of the cravings. It requires the active participation and engagement in treatment. It helps them restore their normal life. I think one of the things that the expectation is that when people are in active addiction, the course is therapy, then we'll see you, which is really difficult for people who are already struggling in everyday life to open up and disclose all these difficult things in their life and try to fight this craving without any sort of assistance. So that alone, just having that first level of medication to help bridge that challenge is an improvement of their quality of life and gives them the opportunity to really take that next step in recovery. Treating the disease treating substance use disorder as a disease is really, I guess, the standard. And then referrals for support and education. There are many. And then sometimes there is relapse, and that is part of the recovery process. People might not get it right that first time or that second time or that third time, but that doesn't mean that we don't treat them still. I mean, I think overall there's many chronic conditions that we see where people don't follow what we want them to do, but we don't not treat them after the fact, after the third time or the fourth time. Next slide, please, Nick. So this, I guess I use this cardiac chain of survival as an example for the same with opioid use disorder. Early intervention, putting the resources out there and opening up that window to have the chance of getting treatment with access. CPR, I guess, well, the CPR and defibrillation, ACLS, I kind of use that as like the harm reduction model. Without those things, people don't have another chance to get treatment and recovery. And then the post-care, that really is the support system and the openness and willingness to continue to care, because there will be hiccups in their path, just like every other chronic disease. So it is really the most effective when for patients when it's provided at the time the patient is seeking care. So in the emergency department, in the inpatient hospital setting after a procedure or because of an infection, when they're showing up to an office with a urine drug screen that shows substances that they shouldn't be using, like those are the times to really provide the best intervention. And it's always better to treat even when you can't ensure it will be continued, or when the patient has not continued treatment in the past. It's just the reoccurring or consistent opportunity, I guess I should say. So MOUD, which I'm not sure if I think I maybe skipped over MOUD, is so medication for opioid use disorder. It really is the gold standard for patients in their treatment. You can see on the screen this cycle of what we want to happen is the referrals. So the ambulance, they come into the ER, they're seen at their home after overdose. However they show up in our medical community, we want them to be referred to the connections to support that change with medical visits and medications to help their cravings and withdrawal symptoms, to get them on the path for an improved recovery.
All right, Christina, I think these are mine now. Thank you. I'm going to transition a little bit. I think Christina did a great job of kind of explaining the treatment opportunities we hope to provide and why it's so important. I'm going to spend a little bit of time talking about why medications like methadone, buprenorphine, and naltrexone, which is the three options that we have for opioid use disorder, why are they so important, and why should we treat for a long period of time? As Christina kept alluding to, is this is a chronic disease. Honestly, the best analogy, that the way that this made sense to me, was to start thinking of opioid use disorder very much like diabetes, and that there's a large environmental component to this, right? How many people got exposed to opioids at a young age? Like, not all that many, but if you did, your chance of developing opioid use disorder was higher. Is it around in your family? Did you have diverse childhood events? Are there other social factors that put you at risk for developing opioid use disorder? And then there's this huge genetic component where we know that about 6% of the population is genetically at risk for opioid use disorder if exposed at the right time. And so, diabetes has similar genetic and environmental component, and they're both longitudinal, long-term diseases that, sure, a subset of people could, get rid of their diabetes with diet and exercise. And the same is true for opioid use disorder. You just decide you're going to stop doing it, and that's it. But we know that fewer than 10% of people are successful with diabetes, right? Most people need medications, and fewer than 10% of people are successful in solving their opioid use disorder just by willpower alone. And so this is why medications come in to really reduce the risk of long-term threat to health and life. And as Christina mentioned, there's no time limit. So some people, we know that at least 6 months of treatment should be a minimum. It takes that long to reduce cravings, to get their life back in order, get a job, repair some relationships, give yourself a buffer so that if you stop these medications and you start to have cravings again, the first thing you do isn't go back to use opioids. You'd have some social support and some coping mechanisms to help. But some people get on medications like buprenorphine and they do well. And if you're doing well and you previously had a 5 to 10% risk of death in 1 year, then you shouldn't stop buprenorphine. Just continue. People go back to doing what they like to do. And so I think one slogan that I really adhere to is that Suboxone, which is a form of buprenorphine, Suboxone is sober. And so if you're on Suboxone and you're not using illicit fentanyl or heroin or buying oxycodone off the street, then as far as I'm concerned, that's sober living, and that's great. So you can see here's the data. Why do we not recommend a quick taper? Which, I think in Grand Rapids, there were some sites that were doing this 4 or 5 day taper. You think, oh, I have opioid withdrawal. I'm going to take a couple days of Suboxone and I'll taper it off and then I'll be done. And the truth is that the cravings return and it continues, and you're at persistent risk of death for a long time after that initial period. And so here, this was a small study. There were 20 people in each group. But for those that tapered, you can see that in the control group, they tapered off of buprenorphine rapidly, and they dropped out of treatment, all of them, by 60 days, and 4 of those 20 people died. And if you were on buprenorphine continuously, you just stayed in treatment for a much higher or longer period of time. And there were 0 deaths. So here's one data point suggesting that medication treatment for a long period of time is better. Here is some more system-wide data. And so this is Baltimore. Baltimore has historically one of the highest concentration of opioid use in the country. It's a port city, started around the 70s when Vietnam was going on, and people would come back with opium from Afghanistan and Vietnam and that whole region. And you can just see here, as you start to increase treatment with methadone and increase treatment with buprenorphine, that the red line, the number of overdoses, starts to steadily go down. And so increased treatment activity reduces overdoses and deaths. Here is France. So France had a tightly regulated buprenorphine policy. And you can see in 1994, they had 564 overdoses, right? So that was an increase of almost 25% from 1993. Remember, we're talking about 80,000 deaths in the United States. And at 564 deaths, France decided to deregulate buprenorphine. And so similar, so they had to have a special waiver, and they just opened up access that anyone could prescribe buprenorphine to anyone. And what you can see is just a steady decline in overdose deaths for the next 5 years. And so I think, there are multiple systems that show that the more opportunity you have for treatment with medications, you'll have decreasing rates of overdose deaths. This one, I know it's a little busy, but if you look, so this, the one on the left, so graph A is opioid overdoses at 3 months. And so this is 90 days of treatment. This is all retrospective. So looking in to see who got 90 days of treatment in which treatment category. So these lines are different. You have a control with no treatment. You have behavioral health inpatient. We have medications with naltrexone only. You have inpatient detox, and you have medications with buprenorphine or methadone, and then just behavioral health as an outpatient. And so this is just, looking at after day one, when you start treatment, who has the lowest rate of overdose death? And that is people on buprenorphine and methadone. Not even close. At the bottom, those that have the most overdoses are those that sought no treatment at all or had inpatient detox. That may sound surprising, but what it really is showing is that things like inpatient detox and prison and jail are really dangerous because it's a period of forced abstinence. And so say you go 90 days of inpatient detoxification, go to your therapy sessions, group sessions, as soon as you're released, your tolerance is significantly lower. You go back to using what you're using before you went into your forced abstinence, and you overdose and die. And this has just been replicated over and over again, that forced abstinence through detoxification or imprisonment are extremely dangerous periods of time for patients. So to reduce overdoses, medications, buprenorphine, methadone are the best. Naltrexone's in the middle. The issue with naltrexone is you have to go about 10 days through withdrawal. So you have to go like with severe flu or COVID essentially for a week to 10 days. And then at that point, you can get the shot of naltrexone. The problem is naltrexone is like a long-acting Narcan. And so if you give someone naltrexone too early, they'll go through severe withdrawal. So you have to wait long enough. It's a really hard period of time for people to get through. And then once you get on it, sometimes you still have some mild withdrawal for those first couple of weeks. And so adherence to the regimen is a little bit less than things like buprenorphine and methadone. So it's somewhat of a challenge logistically, even though it seems like it'd be great to be a naltrexone because that just blocks any opioid use from having an effect and causing an overdose. It's just logistically difficult. The graph on the right, B, is acute care use at 3 months. And so who's coming back to the emergency department frequently while on treatment? And I think many people are worried that if you start people on buprenorphine or methadone in the emergency department, then you're just going to have people with opioid use disorder continuously coming to the emergency department. And the exact opposite is true. If you want fewer patients with opioid use disorder using your emergency department, then you give them treatment. And here's a graph that shows that if you're on buprenorphine or methadone, the use of acute care settings such as emergency departments goes down. And kind of muddled in the middle there is all the other treatment options where you just have continued higher use of the emergency room. I think my favorite graph in the whole presentation. And so how effective and when we talk about medications here, we're talking about buprenorphine and methadone. This is not including naltrexone. So your control, so someone that's using opioids and is not getting any medications at all is this light gray bar right there. Hazard ratio is 1. This is your baseline. If you go into inpatient detoxification, the rate of overdose death is 5 times that if you were to have done nothing. And if you discontinue someone's some buprenorphine or methadone, the rate is almost 6 times that if you'd have done nothing. So Christina had talked about really there's not a good reason to stop someone's medication, right? If you're using cocaine, you shouldn't stop their medications. If they don't show up to visits, you shouldn't stop their medications. There's really no good reason to do it. And this is why, is because if you stop, then you return to something more dangerous and your tolerance has gone down, just like if you were in prison, and you will overdose just at a much higher rate than if you had done nothing at all. On the other hand, the white bar here is medications, buprenorphine and methadone. So if you are actively taking Suboxone or methadone, the chance that you overdose and die is 1/6 that as if you were continuing to use illicit opioids. And so it's just the most effective treatment, that we have. I think the number needed to treat. So you need to treat, I think it's 33 patients with buprenorphine to save one person's life. You look like the number to treat someone with aspirin is in the 90s, right? To treat someone's hypertension long-term, it's say you have to treat 120 people to save one person's life. So we do all these things for chronic disease, yet buprenorphine and methadone have such a higher rate of effectiveness than almost anything else we do. All right, we're going to switch gears and just kind of describe some of the differences between these medications. So again, 3 options. Remember, so we're going to say this says naloxone, but we're going to say naltrexone is the longer acting version, and that's just an antagonist. So it completely blocks the mu receptor, just like Narcan would. It goes in, it binds the mu receptor really firmly. It removes something like fentanyl or heroin, and it revives you if it's naloxone. And if it's naltrexone, the long-acting version, if you inject fentanyl while you're on naltrexone, it just doesn't work. It's completely blocked. And so that's one category. The other category is this full agonist. So methadone completely activates the mu receptor, but it does so in a weak fashion. It doesn't cause a lot of euphoria. It's really long-acting. And so this is another option. Buprenorphine's in the middle. It's a partial agonist, so it partially activates that mu receptor, but it does so extremely firmly and for a long period of time, about 24 hours. So if someone's on Suboxone and they were to then inject fentanyl, they would be protected almost as if they're on naltrexone. It really does block the majority of fentanyl from activating the mu receptor, and it prevents overdose. It also, because it activates the receptor, prevents cravings and withdrawal, because you have activation of the receptor. So these are the 3 options. Buprenorphine is what we do in the emergency department because it's the most flexible. And it's also that methadone has to be done in a methadone clinic. I can't prescribe methadone from the emergency department, but I can prescribe buprenorphine. And so while I think it is the best medication, it's also the easiest for us to do. And so that's why we focus on it. So if you're wondering, methadone, the other difficult thing is that it takes a while to get to effective doses. Everyone has biological differences in how they metabolize methadone. And so you really shouldn't say that someone taking 200 milligrams of methadone daily has a worse opioid use disorder than someone taking 50. It may just be that their liver works differently. But we usually do start at low doses. And so they can have really persistent cravings and continued use in this early phase. And so you start with 30, and then every couple of days you go up by 3 to 5 milligrams until you get the average dose is probably 100 to 120 milligrams. So it takes a while, and you do lose patients during that time, which is why methadone, I think, isn't ideal. Some people need it because in those specialized clinics, you go basically every day, at least initially, and there's nursing support, there's case managers or social workers. And so with people who need a lot of social support with opioid use disorder, methadone can be nice for that reason. For people that have an opioid use disorder that have higher functional status and want to get back to work or taking care of their kids, then daily methadone clinic visits are not great. And so methadone has pros and cons. It just depends on the person. And we've probably all seen that methadone causes sedation. It can cause respiratory depression, and it becomes really risky if you start taking it with other opioids or benzodiazepines. The respiratory rate can really drop. It also prolongs the QTC. Yeah, and so yeah, almost daily dosing is pretty common. Sometimes if people have been in the methadone clinic and have shown reliability, then you can get take-home doses or space-out dosing where they go twice a week and they get 3 days each time. That's pretty common as well, but it does take some time for that to occur. So naltrexone is that high affinity mu receptor antagonist. So it's a full blockage. You can give it in an oral version, but adherence is much less, right? If you're having a bad day and you want to use fentanyl with your friends, you just stop taking your naltrexone for a day and then you can use it. And so that's why it's preferred to get the intramuscular version where it lasts about 30 days. So you get a shot once a month and then you can't use opioids. The issue is that you have to go through withdrawal first, and most people just can't do that. But I think it's good in a couple of situations. So if you've had someone who's actually, like if you're adherent to detox program, you're inpatient for 90 days, you've gone through opioid withdrawal, they should be giving patients naltrexone injections, because when they go home and they decide that they want to use opioids, then they won't overdose and die. Same thing, prisons, some do, but they should be more frequently giving intramuscular naltrexone upon release, so that if returned to use, then they don't die. Of course, this should all be, consensual, but to reduce the risk of overdose from abstinence, naltrexone can be helpful. And for some patients that do want to not be on any medications, right? I think Suboxone is sober. Many patients don't agree. And so they see being on buprenorphine as something less desirable. And so, after 6 to 12 months of treatment, when things have been going well for them, if they slowly want to taper down at that point and then be on naltrexone, so that if they have a bad day, they don't die from it, I think that's an appropriate use of naltrexone. And so there is a place for this. It's just probably not the first thing you want to do if you have severe substance use disorder. It's just a hard drug to do right away. It does decrease cravings. This also works for alcohol use disorder. So you will sometimes see that people with alcohol use disorder are on naltrexone either orally or intramuscularly. And these are just patient-reported cravings for opioids. And you can just see that they just don't desire the drug. You get a lot of positive reinforcement when you get the high from an opioid. And if you have naltrexone and it doesn't do anything for you, then you don't crave to do it. So buprenorphine, the star of the show, is that high affinity. It binds really tightly like Narcan or naltrexone, but it's a partial agonist. So it also gives you some pain relief, prevents cravings, and decreases return to use. It works about 24 hours or so. So you can do it once daily dosing if you want, but the analgesic properties, so basically the plasma concentration of the drug, is high for 4 to 6 hours. And so if you're having pain, you can give it, and expect that it'll work for 4 to 6 hours. And so it is a nice use for someone who's having a painful condition as well. But really the big benefit for buprenorphine, it has a ceiling effect in respiratory depression. And so even at high doses of buprenorphine, you would not expect patients to have reduced respiratory effort. And so you can overdose and you'll keep breathing. It's just kind of like a high dose of alcohol, typically, where you're very sedated, but you're not going to die from an overdose as long as you don't start mixing it with other sedatives, such as high doses of alcohol or benzodiazepines. So very safe drug. The trick is that it's only absorbed sublingually. So if you swallow it, it doesn't work. You can also inject it, but at a much lower dose. So due to this, you will often see that Suboxone, which is the most common form of buprenorphine, is both buprenorphine and naloxone, right? You'd think, why would you give someone naloxone who you're giving buprenorphine to? Wouldn't it block it? Well, no, because naloxone is not absorbed sublingually or even when swallowed. And so what you have is, if taken appropriately, buprenorphine is absorbed under the tongue or buccally, and you get the medication, but the naloxone does not work at all. If you you melt down the buprenorphine, the Suboxone strips or tablets, and melt them into liquid and inject it. If you did that with just buprenorphine by itself, you'd probably overdose because it's a very large dose to inject. But at that point, the naloxone would be active and counteracts the buprenorphine. So it blocks the dangerous diversion or inappropriate use of buprenorphine. So that's why it comes in combination as it does. Sometimes you'll see people on the mono product, which is just buprenorphine, but really there's no use in doing that anymore. They used to do it for pregnant people because they were concerned that the naloxone component could adversely affect the fetus, but that's not a worry anymore. And so really everyone should be on the combination product because it's safer. So here is the graph showing how your breaths per minute does not decrease with higher doses of buprenorphine. Most people are on 8 milligrams of buprenorphine twice or 3 times a day. And so you can just see really, once you get to 4 milligrams, your respiratory rate doesn't decrease. And so you shouldn't overdose and die. Here's another example of that. These are steadily increasing doses of buprenorphine, 300 micrograms, 300, 600, 900. And your minute ventilation, so how much carbon dioxide are you expelling, does not go down. Whereas when you have equivalent doses with oxycodone, you get 30 milligrams here and 60 milligrams of oxycodone here. No surprise, at 60 milligrams of oxycodone, people stop breathing. But that doesn't occur in people with high doses of buprenorphine. Another question for you all. All right, so another concept important to understand, Christina had talked to you about the clinical opioid withdrawal scale, right? So this is like CWA, but for opioid use disorder, and you're going to measure how bad someone's in withdrawal. The reason it's important to know is because you can't give buprenorphine until someone is in severe enough withdrawal. So if they are taking a full agonist, say morphine, heroin, fentanyl, methadone, right? And they're on this green line up here. And you then give them a buprenorphine before they're in withdrawal. What happens is that buprenorphine bumps all these medications off of the receptor and it brings them down hard and it makes them go through withdrawal. Just like if you give someone Narcan, right? You can make them sick right away. So what you have to do is you have to make sure that you follow this green line until it's an arc, until it goes below the blue line, right? So they start to get sick. You want to, usually a clinical opioid withdrawal scale of 8 or more. And at that point, then you can give them buprenorphine. So if they're down here, you bring them up, they feel much better, their withdrawal symptoms get better. If you're above the blue line and they're still high on their opioids, you bring them down, they get sick. So this is why it's so important to know what someone's opioid withdrawal scale is, or their score. Because if you give buprenorphine too early, it makes people worse. And so I think in the emergency department, a lot of times what I do, probably the majority, is I give people prescriptions to take at home. So I print out how to do it. tell them which signs to look for, and when they are sick enough, I just say, wait as long as you can. If you can't wait another minute without using fentanyl, then take your Suboxone. If you can wait another 5 minutes, then wait another 5 minutes. And if you can wait as long as possible, it reduces the risk that you get sick.
Nick, can I just jump in and add something here?
Yeah.
For the emergency department, when we see people come in via EMS after an overdose and they've been Narcaned and they are in this withdrawal and they are really very difficult to deal with, but that's also, I guess, something to remember when trying to help them and treat them, that they need something to help that withdrawal versus restraints and some of the other things that we do in the hospital.
Yeah. And this is why I offer Suboxone. I've done this a couple times, but if someone's sick from Narcan, if opioid withdrawal is the problem, which opioid withdrawal is the problem if you give someone Narcan, they're in withdrawal. It's precipitated from medication, but it's still withdrawal. Then buprenorphine is always the right answer. And so if someone is sick for an opioid withdrawal, then offering buprenorphine should be the next step. And so if you give someone Narcan or EMS did and they're very sick, then it's often a good time. They're very receptive to treatment with buprenorphine because they know that they'll feel better. The nice thing is that once you make them feel better, they're either on it and then you can prescribe it, and so that they're just on it until follow-up, or even if they say, no, I'm not interested, I don't want to do it, they're safe for the next 24 hours because that buprenorphine is going to block whatever they're taking on the street. And so, that the 1 year mortality for opioid use disorder in the emergency department is 5 to 10%. But 0.2% of those people died within 24 hours. And so even if you're saving someone for 24 hours, that's a fair number of people. And so it's always a good time to give Suboxone, even if it's just when they're in naloxone precipitated withdrawal. People worry frequently about diversion. So if we start prescribing Suboxone and buprenorphine to people, are they just going to sell it? Are people going to come in overdosed on buprenorphine? I think we already addressed that. That shouldn't happen. And surveys show that it's not a super desirable drug for people to use recreationally. Only about 2% of people who use opioids use buprenorphine to get high. The vast majority of people who report using buprenorphine that they buy off the street is because they want a prescription and they don't know how to get one. So treatment is often difficult. Christina showed the maps about where there is these gaps regionally and geographically. And if there is a high rate of buprenorphine diversion in a region, it's typically because there's not enough people prescribing buprenorphine or offering counseling for it. And so we shouldn't be worried about diversion of buprenorphine. It's not usually done for recreational purposes. It's not done dangerously. It's usually people trying to stop using drugs on their own. And then when they follow up in addiction clinics, their drug screen will have buprenorphine and metabolites. And so you can see if someone's actually using medication. Christina, I think it's back to you. Christina,
you're muted.
I got you muted.
Sorry. Okay, now I'm here. So the resources that really help for recovery from a substance use disorder of whatever substance the person is using is recovery coaching. So these are people who have been through this. They've struggled, they've gone through treatment, and they have come out on the other side and are trying to help people get there too. The coaches, we do offer them at Munson, and I know some other hospital systems are also providing them, but they really are the motivator and the cheerleader and the support person. They are the people who when the person is in the hospital and feel like they have nobody and everybody's against them, they're the person there to say, nope, this is your options. This is what we can do. How do you want to do it? So they are really our window into a lot of people's recovery and help get the patients onto that path of recovery. So the impact of peer recovery coaches is really pretty remarkable. I think in my own experience working with people who have come in with withdrawal or an infection related to their drug use, whatever the story might be, they have often been the person to kind of bring the patient back to like, we're here to help you. I'm here to support you. And it does help with their long hospital stays or even just being a person to introduce them to some sort of treatment option. Like Nick said earlier, that a lot of people are using Suboxone or buprenorphine from the street because they don't know how to get it on their own or get help on their own. The peer recovery coaches not only offer the medication treatment, but they all offer like resources for group meetings or I mean, it could be it could be something as where they're going to get their next meal or how they're going to even get to the doctor's appointment. They are really a huge bridge for patients who are trying to get treatment for their opioid or substance use disorder. They also develop relationships with the medical community so they can relay some of that information on what might help us help them, which has been super helpful. Harm reduction. This seems to be sometimes a challenging topic for people to accept, medical or non-medical. But the reality is it's like, I mean, many other disease preventions. So vaccines, when you're trying to quit smoking, nicotine patches, like it's just an option to get them to the next step. So naloxone, it can revive people and give them the opportunity to seek the next step in their treatment. Syringe services programs, they not only provide
Christina, are you still there?
medication treatment options, whichever path that person might need, it's another avenue for that opportunity. Medication take back, those are really just an option to get rid of anything that might be dangerous or misused, not only with people who have substance use disorders, but I think often recently teenagers and their weird TikTok challenges or whatever the cool thing is to do. Like if you don't need the medication, there's no use. There's no reason to keep it. And then the other one is to never use alone. So we have a national, I guess I can change the next slide, a national, sorry, I skipped this. So these are some options for naloxone to get for anybody. These will be shared and they're pretty easy to find. Some of them will mail them to you. There are many places that just have it for free, even though the FDA approved it as a over-the-counter medication. There's still some fees associated with that. So having the free resources is really beneficial. The nasal naloxone is really simple to use. They usually come in a 2-pack and it's very easy. Sometimes we do harm reduction is one of the ones that still provides the IM injection, but that is free, and they also offer a training for it. Safe Syringes program. This is what I talk. They provide all of the things in this picture: community resources, safe sex, condoms, foam, clean needles, and supplies that if you're going to use, they also provide the information, and fentanyl strips, fentanyl test strips, which is really important recently with our high fentanyl in many substances. Just some information about why safe syringe programs are beneficial. They really do contribute to reduced viruses, and they do provide up to 5% recovery for those people who are introduced to it. Proper disposal of syringes, which you may or may not have come across out in public somewhere, and then the introduction to recovery services. This is the never use alone. So, not everybody is ready for recovery or treatment. And even sometimes, even if they are, they do relapse. This is a resource to contact for if you're going to use, to have somebody on the other side. No judgment, no stigma, I guess, about your drug use, but it provides an option that they'll be on the phone with the person who's using, and if there is no response after, then they can contact the emergency services to get help. They also provide other services like resources for treatment. We do have a large area of medication take back throughout the state. And most of them are sent to incinerators, so there's no concern for if your name's on it or who's dropping it off or what it is, illegal or legal, prescribed or non-prescribed. There's really no question asked. It's just drop to get rid of it. And then our treatment resources, these are our regional contacts for treatment. So they have all the information that can link people to substance use disorder treatment. A couple, these at the bottom, the Angel program, that is something that's fairly new to Northern Michigan. I know Southeast Michigan, I think, has had a longer standing program, but they offer the option for people to come into the state police post and say, I need treatment. And they will link them, provide them with transportation, because often that's the huge barrier, is transportation to a treatment that might have availability. And then the 998. So even it's suicide, but it's also crisis. So if somebody is in that state of crisis, they can provide the services or linkage to the services to help get them help. And that is all I have. We have some time for questions if there are any. I think because I had to switch from my computer to my phone, I lost a lot of the chat. There was a question about, oh, never mind, it was addressed, but the evaluation will come via email.
All right. Well, it doesn't seem like we have any questions, and that's fine. If you think of anything, feel free to email us. But thank you all for your attention. You guys are a great audience, and thanks, Christina, for all your hard work.
Oh, thank you. There's just a
Right.
question that popped up.
We have one.
What work is being done in the state of Michigan to increase treatment availability? Well, I guess I mean I can speak to this project right now that we're working out of is the Community Foundation of Southeast Michigan and the Michigan Opioid Partnership to introduce this treatment into our hospitals. I mean, that's been huge, I think, just to provide that first door into treatment. I do know, at least for Grand Traverse County, there was a big meeting for our opioid settlement funds, and our health department has a very robust plan to do treatment. I don't know, Nick, if you can speak to any other
Yeah,
effort.
I think it's, almost half now of emergency departments we've worked with. So that's one location. The Michigan Opioid Partnership also helps facilitate jail treatment activity. And so the number of jails that have provided access to treatment have really increased significantly. The Michigan Opioid Collaborative is out of the University of Michigan and works with primary care teams to expand treatment. And then the HEART Initiative is a Michigan-based program that's working with hospitals to increase addiction medicine consulting service. So, whether it's through jails, whether it's in the emergency department, primary care, or inpatient, there's currently a team working on it throughout the state. Elizabeth says a follow-up is hard for patients after ED treatment. Northern Michigan needs more clinics to help manage addiction recovery. This is absolutely true. I think number one issue is stigma, and number two is emergency departments are worried about where they're going to send patients to. We do work with hospitals. I know that my team with Michigan Opioid Partnership met with a couple hospitals in the state last week. There are telehealth options, right? There's we work with the Michigan Opioid Collaborative because they know in each region who's doing this. And so if you feel like your emergency department doesn't have a good follow-up, reach out to us and we can certainly help facilitate conversations and relationships. But I agree with you.
Yeah, and just to add on to that, Elizabeth, I think that that's part of my role too, is developing that. We have a lot of partners in our Traverse City area, but we are trying to expand that with our emergency departments in Wexford and Charlevoix. And unfortunately, it is a new and challenging process to systematize. So we are working on it with our primary care providers for that like direct follow-up, that soft hand up or that warm handoff to know that the patient will be leaving the emergency department or the hospital and have an appointment with a provider to follow up, just like they would with a cardiac or any other specialty provider.
All right. Thanks, everyone.
Thank you.